We're taking this, 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 we're taking with a pinch of salt.
Welcome to A Pinch of Salt, the official ERA podcast. I am Hugo Diniz, an interventional nephrologist from Porto, and your new podcast host. This is a very exciting debut for me, as we are just coming to you live from the 63rd ERA Congress in Glasgow, and we have just walked out of what might be the most packed Clyde Plenary Room I've ever seen. We've just attended the late-breaking clinical trial session 1. We had 5 trials during 90 minutes with a brand new drug class in CKD, semaglutide and what patients actually feel, 2 IgA nephropathy therapies going long-term, and even anticoagulation in advanced kidney disease. To help me make sense of it all, I have with me Professor Alberto Ortiz and Professor Danilo Fliser, 2 true titans of European nephrology who were sitting in the chairs at the front of that room. So let me properly introduce them. First of all, we have Professor Alberto Ortiz, who is the head of nephrology and hypertension at Fundación Jiménez Díaz in Madrid, and the current renal science chair of the ERA. Alberto, welcome to A Pinch of Salt.
Thank you.
Thank you for being here. And also Professor Danilo Fliser, who is a professor of medicine and directs internal medicine 4 at Saarland University Medical Center, and served as the ERA's renal science chair between 2018 and 2025, and also received the ERA Award for Outstanding Contribution to the Society here in Glasgow. So Danilo, congratulations, and it's also great to have you here.
Thank you. It's a pleasure.
So just let's go straight. Let's kick off with the new kid on the block. We had our own Professor Christoph Warner presenting the phase 2 dose-finding data of nurandociguat, which is a new class of drugs, a soluble guanylate cyclase stimulator. So we've been known the nitric oxide pathway in CKD for quite some time. It's been a bit of a sleeping giant, we might say, because the SGLT2 inhibitors have been taking all the headlines in the last couple of years. But in the meantime, this whole nitric oxide soluble guanylate cyclase axis was being rebuilt as a drug target. So we now have randomised, avansiguat, and also nurandociguat, all in clinical development. So Alberto, what did this dose-finding trial tell us? Is there a sweet spot? Does this class look like it has real legs? Are we maybe even looking at potential new pillar of kidney protection?
Okay, so let's begin with the class. Nurandociguat has been studied as an antiproteinuric drug. It's no longer in the Bayer pipeline. I checked today the web page. It did decrease by almost 50% proteinuria in both diabetes and non-diabetes, on top of RASI and SGLT2 inhibitors, but there was peripheral edema, anemia, and maybe that's the reason why it appears to be abandoned. Avansiguat again decreased proteinuria in CKD, but I saw no phase 3 clinical trial ongoing in CKD. It's now being developed for systemic sclerosis.
Okay.
So now we have nurandociguat as the last one standing for now. So this dose-finding clinical trial tested 5 doses of nurandociguat in CKD patients with or without diabetes, GFR between 20 and 75, albuminuria over 200 milligrams per gram, primary point change of albuminuria at week 16, so relatively short follow-up. The mean blood pressure systolic was 135.
Okay.
And this is important because the main issue with the drug was symptomatic hypotension.
Yeah, and we saw some drug discontinuation, particularly in the higher dose.
That's it. The good news, most of the patients were on RAS blockade, 70% of SGLT2 inhibitors.
It's quite good.
Almost 1 in 4 on finerenone, 1 in 6 on GLP-1 receptor agonists.
Yeah.
But for the diabetes
Mixed population, of course.
that would be roughly double. So what we are observing is on top of the standard of care.
Yeah. Mm-hmm.
And the albuminuria decreased by up to around 20%. However, this like optimal result was obtained with 10 milligrams per day, which was also associated with a 25% abandonment of the drug.
Yeah.
And with symptomatic hypotension. Yeah. So let's see. The good news, apparently they are designing a phase 3 clinical trial.
So maybe too early to tell, but maybe the lower doses might have some legs.
That's it.
Okay. So now let's transition from this new mechanism and the new class of drugs to a new way of looking to an established one. So we had Professor Juan Esman presenting the quality of life data from the FLOW trial. We already know the results that semaglutide slowed kidney decline, reduced cardiovascular death, and even cut mortality for about 20% in patients with type 2 diabetes and CKD. Those are hard endpoints, no argument there. But here's the thing. Hazard ratios don't tell a patient how they're going to feel on Monday morning. So Danilo, what does this new data tell us? Did the semaglutide actually make patients go with the flow, or the lived experience stays roughly the same?
Well, you very well pointed out that as physicians, we usually look at the hard endpoint. That's what we are interested in. But the opposite view is the view of our patients, because our patients have so many comorbidities that they want to have a good life. They want to have also a good quality of life. They do not care so much about the endpoints. Yeah,
I agree.
And I think this is an important question that they ask in FLOW. Does it just reduce the endpoints, what we look on, or does it bring it also a better life to the patients? And the results showed that indeed the improvement in quality of life was significant. However, we don't know what this really means in real life, because this was a self-reported improvement. We have no hard data on the quality of life, like physical performance and so on. But I think it's a first very important step to look on this dual outcome of an intervention, not only on the hard endpoints like mortality, morbidity, but also how people perform when they are on track.
Yeah, so maybe we should strive for hierarchical composite endpoints, and also have the patient experience and their improvements in maybe physical capability or their symptom burden. I think it was very interesting to see that the patient reported increased mobility and self-care, which is very important. We have our patients to be capable of doing their daily activities. I think that's important for them, but also important for us physicians. But did you find in the data some quality of life cost, maybe related to gastrointestinal or some of the side effects that kind of offset the other gains, or was something reported there?
Well, they didn't report a specific endpoint, but I think that Johannes pointed out a very important thing, namely that the hospitalization, first hospitalization was reduced. And we know that going to the hospital, besides if you are a physician, that's okay. But if you are a patient, that's less happiness providing.
Yes.
So I think that this is a very important point, that hospitalization was reduced. And of course, this improves also quality of life.
Yeah, I think it really makes, at least extends this clinical profile of the drug beyond just the kidney outcomes we already knew. Okay, so that's great. Now let's move on to IgA nephropathy. So we had not one, but two IgA trials in this session. So let's just take them in turn. So we'll start with what Professor Ido Irsping showed us. So he presented the 2.5-year eGFR data for atrasentan. This was a trial with a dose of 0.75 milligrams once daily. So we know that this drug blocks the endothelin A receptor. This is also a pathway we've known for decades. It's also had a bit of a bumpy road in kidney disease with some failures. But, Alberto, we have these proteinuria results for a while, and they show an impressive reduction. Now it seems to be the standard in this kind of trial, so about 36% of reduction. But we know that proteinuria is the promise, eGFR is the delivery. So did atrasentan deliver on that promise over the 2.5 years?
Yeah, I believe so. So, as you said, we have 2 clinical trials with very similar baseline GFR and proteinuria values. One non-specific kidney protection, the other targeting complement. So, what were the results? Mm-hmm. As a baseline information, atrasentan is already approved in the US based on the proteinuria data, and now we had the final analysis on glomerular filtration rates. Mm-hmm. So there was a 2.4 mL per min per surface area difference at the end of the trial between placebo and atrasentan. The good news is that when you look at the subgroup on SGLT2 inhibitors, they were stable kidney function. Yeah. As compared to a loss of 8 mL per min per square.
The difference was quite striking. Yeah. I mean, it was a smaller group. I mean, it was about 40 in each group, I believe. But it's very promising that if you have patients on the baseline therapy, we might get even better results with this new drug.
We haven't started talking about immunosuppression.
Yeah, that we'll get that. So it looks like this selective approach might finally get it right, at least with the SGLT2 inhibitors.
At least from the kidney point of view. Let's remind that other kidney protective therapies also provide cardiovascular benefit.
Okay. Yeah.
Okay. So I think that would be important. We don't have that information for immunosuppression, for example. Okay. It was interesting that the main adverse effect was fluid retention, which is very well known for this class. Yeah. The good news is that it was less common when combined with SGLT2 inhibitors.
They probably balance each other out. Yeah. And did you find it particularly interesting that when they stopped the drug, there was no return, a bit of an increase in the eGFR and in the proteinuria?
Yeah, no, there was no big impact on the eGFR after stopping, but in any case, there was no eGFR dip to start with.
Yes.
So this suggests a different mechanism of action of the antiproteinuric effect that the other drugs that we have for kidney protection. Interestingly, the antiproteinuric effect disappeared within 1 month of stopping the drug. Mm-hmm. So it doesn't appear to be hemodynamic, but still it's like acute.
Yeah.
And so the hypothesis that was proposed is that it may influence the glycocalyx of the endothelium, and that you need the drug to be there so as to have this influence.
Yeah, that's a hypothesis. And also, it doesn't really influence blood pressure, as Professor Irsping also mentioned. Also, just slight change. So maybe an advantage, maybe a disadvantage.
In any case, the systolic blood results.
We didn't see results yet.
The systolic blood pressure of these patients was at baseline was quite good, 124.
Yeah, okay, already.
So it's different from other trials that we're discussing today, in which it was a little bit higher.
Okay, so let's go now to the second IgA nephropathy trial. So same disease, but a completely different mechanism. We had Professor Jonathan Barrett presenting the final applause IgA nephropathy subgroup analysis for iptacopan, which is an oral complement factor B inhibitor. We already know the 24-month data. It's also already published. We briefly discussed this today. The eGFR slope was essentially halved compared to placebo, and the composite renal endpoint reduced by 43%.
Okay.
So Danilo, today we had a bit of a different approach. So Professor Barrett zoomed in different subgroups. So which IgA nephropathy patients get this bigger applause and benefit the most?
Well, this was one of the surprises for me today, because there was actually no real subgroup advantage. John Danilo Barrett also pointed out that when they looked at the pathology, there was not really a difference between the groups. One would expect that those with a more active IgA nephropathy would benefit from an immunological treatment like complement inhibition, but this was not the case. Those with the chronic or residual
Lesions, so
lesions,
tubular atrophy,
had a profit. And the second surprise that came today for me is the point that we have one disease. We look on IgA nephropathy as a one disease, but we have now myriad of treatments with a completely different pathophysiological aspect that all work. It's not only SGLT2 inhibitor, RAS inhibition, and blood pressure lowering, but obviously it's also endothelin inhibition. It's obviously also complement inhibition, and as it had, of course, immunosuppression, as Alberto pointed out, with steroids, for example. So I think it will be quite difficult in the future how to use all these drugs and how to decide start with which drug, who has this pathology, who has this pathology, or do we start with all of them?
Yeah, we're going to just discuss that briefly a bit, but before, I think also, I think the data is clear. It works in almost every subgroup, so I think it was a bit surprising also. Maybe complement also has a role in the tubular interstitial atrophy, as Professor Barrett mentioned. But when we look at that subgroup of patients that had less proteinuria at baseline and started the drug earlier with SGLT2 inhibitors on top, they were the ones that basically entered clinical remission, if we can call it like that. So we have to change our mind about IgA. We have to start biopsying them very early and starting them very early on targeted treatments.
I think that we have to change our mind, that we have to start to treat our patients when we know that there is a progressive chronic kidney disease very early, not to wait until GFR falls to 60. But if they have a normal GFR, it's a clear sign of a chronic progressive kidney disease, we have to start immediately, not to wait. If we have the particular pathophysiology background, like complement inhibitor, for example, C3G, and then we can start very For IgA nephropathy, of course, it's a bit more difficult because we don't have those biomarkers like for C3G, but nevertheless, if we have an active IgA nephropathy, I think we have to start immediately to treat the patient to stop progression.
I think that connects beautifully with the next part of our discussions, because we have now these therapies back to back, one hitting endothelin, the other hitting complement, different targets, different mechanisms. Are they potentially complementary? I mean, are we, as we're probably heading towards this combination therapy and kind of precision and tailored approach? I mean, also the 2025 KDIGO guidelines certainly laid the framework for this, at least for high-risk patients. What do you think, Alberto? Are we on the right track?
I think we are on the right track. Now we should put our part, which is earlier diagnosis IgA nephropathy. And for that, we need biomarkers, because with kidney biopsy, you will always be late. Being invasive, you don't biopsy patients with 50 milligrams albuminuria.
No, of course.
So people with IgA nephropathy with a proteinuria of 1.5 grams, they were not born that way.
Totally agree. Yeah.
And so we should move towards earlier diagnosis, potential biomarkers, and let's think about how to combine these treatments. Perhaps we should first induce remission with some kind of immunosuppression, generally speaking, including complementary inhibitors, but maybe that's not for life.
Yeah.
And then you keep on with non-specific kidney protection.
Because they're also, and we have to point this out, quite expensive. Now coming to the market, we are not speaking about 10 euros per day, like for SGLT2 and so on, and GLP-1, we are talking about hundreds of euros per day treatment costs.
Yeah.
Therefore, we should have some kind of, randomization of the patients according to biomarkers that we not yet have. That's the point.
Yeah.
So we are going a bit ahead with our treatments and do not have yet the possibility to decide whom to give what.
Okay. Maybe hematuria might play a role. I think some colleagues, at least from Mayo Clinic, are very proponent on looking at hematuria more closely and is a marker of glomerular inflammation in IgA. Maybe it's a very controversial topic, but
Yeah, I think we have a view on how we assess hematuria.
yeah.
So we should standardize the timing between sample collection and assessment. We traditionally look per high power field. My hospital reported as a single cluster 1 to 5 herbal cells per high power field. 5 is 5-fold 1.
Yeah.
So you cannot put that. Now we have flow cytometry that provides a precise number. Still, the denominator is volume, which is no good because urine can be more or less concentrated. But perhaps expressing regular cells per gram of urinary creatinine or something like that.
Yeah.
That maybe make it more quantitative and more stable.
And I think we have to be also more reluctant to other clinical signs in that we have. Like, for example, when a young man
He's a man, yeah.
with this unexpected high blood pressure, we have to make a check because it's like Alberto pointed out, with 20 you don't have high blood pressure. If there is high blood pressure, either you have a genetic background or you have a kidney disease.
Yeah.
And we have to check this. We are not looking as we should.
Yeah, hypertension is definitely a sign that often gets overlooked because it's so common and we don't connect it with kidney disease. Okay, great. Let's now just shift gears a little bit from this mechanism point of view to the messy reality of clinical practice. We had a great presentation by Professor Sunil Badwe from the George Institute for Global Health in Australia. He presented a quite interesting trial named TRACT, which tested the hypothesis of rivaroxaban 2.5 milligrams twice daily in patients with advanced CKD, so stage 4 and 5, and even on dialysis, in order to reduce major adverse cardiovascular events in a high-risk population, so prior cardiovascular events or diabetes. And this is a population that has been essentially excluded from the classic anticoagulant trials in the past, and half of the patients were on dialysis, which is impressive to say the least, and 3/4 had diabetes. And I mean, Alberto, this is a question that we kind of been asking in our daily practice for years now. Can we really safely anticoagulate these patients for cardiovascular protection? What does this new data tell us?
Yeah, indeed, the anticoagulation of dialysis patients, for example, there is a huge variability in clinical practice depending on specific nephrologists, specific cardiologists, and this try to answer the question. So I think it was a very brave trial. So just as background, rivaroxaban may be used up to doses of 20 milligrams per day, up to 30 for short time periods for venous thrombosis. But for prophylaxis of atherothrombotic events, which was the aim of the trial, it's used at 2.5 milligrams twice per day, which is the dose of the trial. However, when you look at the assessment by regulatory agencies, they do not recommend the drug in people with GFR below 15.
Yeah.
They recommend to be careful when GFR is between 15 and 30 because there is that there is an increase in the anticoagulant potency, so it is almost at 2.5 higher prothrombin prolongation in cases with G5.
Okay.
So it was brave. It tried to answer the question, but unfortunately they found no evidence of efficacy. The hazard ratio for the primary outcome of cardiovascular events of MACE was over 1.0, not statistically significant, but still over 1.0. Risk of death, again, over 1.0, not statistically significant. And there was a statistically significant 50% effect risk of major bleeding. So the trial was terminated and we have no response yet.
Yeah. And it's a bit also surprising because we have other anticoagulants that at least the safety profile seems better than rivaroxaban, like iptacopan, but some of us have already using it off-label in dialysis patients. And and also had some idea that even comparing low doses of rivaroxaban to this iptacopan is also worse in advanced CKD. So, Danilo, is this maybe the right track for advanced CKD is to not anticoagulate patients, or at least for those elderly?
Well, the results of this trial did not come with a surprise. We had all these signals of safety in previous trials, smaller trials, observational trials, that there is a much of bleeding tendency in our patients. The more they progress, even patients on dialysis have high bleeding tendency. This is not a surprise. However, I think that we have a little bit to look more closer on this trial. This trial actually can be looked as a primary prevention trial. Because we have a population and we want to prevent an event. However, even in this trial, there was less venous thrombosis observed. And if you have a clear indication for anticoagulation in a CKD patient, I think we still have to do it. If somebody had venous thrombosis, you have to give anticoagulate. If someone has an artificial valve, you have to give anticoagulation. Even in those patients with CKD stage 5 on dialysis. Yeah. So this is what I would say secondary prevention is still there. The point is, Alberto already pointed out, it's not completely comparable with the cardiology, because most of the cardiology patients were included because they had atrial fibrillation. Yeah. In this trial, we had a very low proportion of patients with atrial fibrillation. I was surprised because usually if you have increasing stages of CKD, you have more and more atrial fibrillation. Yeah. So how did they succeed to put so?
Yeah, maybe they were already anticoagulated.
They were probably already anticoagulated.
Yeah, that's why they couldn't be enrolled in the trial.
Yeah, I suppose that's the truth. And well, this question is answered, not to do it in all patients, but still there are probably some subpopulations where we have to do anticoagulation. But you have to decide very
carefully. Yeah. I mean, 50% of an increase in bleeding risk is it's more.
Sure.
It's huge. Okay, so before we wrap up, I'm very curious to know, I'm very eager to know. So what was the one result that generally surprised you today? So not the one you expected to be good, but the one that made you sit up in your chair, let's say. So let's start with Alberto.
Yeah, it is. For me, it was the fact that both AN nephropathy clinical trials that they had, they appear to be the same patients. Same GFR, same proteinuria, two totally different approaches, very similar results. So how do you incorporate this into clinical practice?
Yeah, it will be a challenge, and we'll need a lot more data for sure.
I can join in.
Yeah,
I already pointed out that very surprisingly, completely different pathophysiological background, the same result. It's interesting.
Yeah, it's very surprising that we had so many years. I mean, like We know the disease for about 50 years, I believe, and in the last less than 10, I believe 7 or 8 years, we've had so many positive trials, and the last landscape of the IgA nephropathy therapeutic options being so different. So yeah, that's what we have to unpack now for clinical practice. So we're reaching the end. So we've covered 5 trials in one session. So a potentially new drug class in CKD, quality of life with semaglutide, these 2 IgA nephropathy therapies going long term, and even anticoagulation in advanced kidney disease. I think it was brilliant late breaking clinical trial session. Tomorrow we'll have another one, which will be also very interesting. But for now, it's a wrap from Glasgow. Thank you both, Professor Ortiz, Professor Fliser, for joining us live on A Pinch of Salt. And to our listeners, if you enjoyed this, please like and subscribe wherever you get your podcasts. And I am Hugo Diniz, and until next time, remember to always take everything with a pinch of salt.